Right, guys, so this is the last cranial nerve, the hypoglossal nerve, okay? So it's the 12th cranial nerve found in the lower medulla oblongata, okay? And if you take a cross-section, right, of the medulla oblongata, we'll see that the nerves of the hypoglossal nerve will enter just at the boundary of the fourth ventricle, and this is where the nuclei of the hypoglossal nerve are. So the fourth ventricle is just a space where the CSF get drained and recirculated, basically. Okay. So this is purely a motor nerve. Okay. It has no sensory function. It only provides basically action for muscles of the tongue. That's why it's called hypoglossal nerve, as in glossal meaning tongue. Okay. And after it has its nuclei there near the fourth ventricle, it will exit a particular foramen known as the hypoglossal canal. Okay, so this is one of the few cranial nerves that actually have a canal or opening named after it. Yeah, so not only does it have innervation to like I said, the tongue muscles. Okay, so the genioglossus, the styloglossus and the hyoglossus. Okay, it actually goes down deep into the neck between the internal carotid and the internal jugular vein. Okay, and it forms along with the cervical nerve, so like C1, 2, and 3, I believe. It actually forms like an arc called the ansa hypoglossalis. Okay, it's basically an arc which will provide innervation to the muscles of the hyoid bone, which is like the little chin strap bone basically under your neck. Okay, but that's not really that relevant because clinically we're looking for tongue muscle action and not really the hyoid bone action. So examination, okay. When we look at examination, always start with the symmetry. Just look at the tongue, see how it looks like, see if there's any deviation from one side to the other. Okay, one of the ways in which we can sort of examine the tongue, we can just ask the patient to move their tongue from side to side or protrude it forward, whatever. Okay, and we can even do a power test where basically this is the mouth of the patient. We get the patient to basically move their tongue to one side of the cheek. So this is the cheek, right? And then using our finger, like the clinician would use their finger and basically press against the cheek whilst they are pressing their tongue against it. So, and then you just ask the patient to basically use force against your finger on the cheek. And that basically tests how forceful, how powerful your tongue muscles are. So in terms of the syndromes, right? The syndromes, so remember that there is no sensory syndromes because again, this is a purely motor nerve. It's only the motor aspect that we're looking for, okay? So like nearly all motor nerves, we have the upper motor neuron part and the lower motor neuron part, okay? So here we call this actually a supranuclear lesion. So anything above the nucleus, because remember, a lower motor neuron counts from the nucleus downwards, whereas the upper motor neuron counts as anything above the nucleus. So if you think about the brain, this is the brain, this is the nucleus, and these are the nerves, and then you have the muscles. Okay, so with the cortico-nuclear tract, so basically the tract that goes from the brain to the nucleus, it's going to decussate. Okay, and a very important point about the hypoglossal nerve is that there is no bilateral innervation, unlike 9 and 10. So it doesn't have two nerves going to one nucleus. So if one nerve gets basically dashed, then that whole tract is gone and there's no backup for it. Okay, so that's important because if this is the right side, this is the left side. So let's say the right side got sort of dashed or destroyed, whatever, damaged. It's the left side of the tongue that will get affected. And basically what you're going to see is that the tongue, it's supposed to be a tongue, the tongue will actually go towards the affected side, the paralyzed side. Why? Because you have no tongue muscle action here. That means the tongue is the other tongue muscle, because tongue muscles are paired. The other tongue muscle, which is healthy, is going to push it towards the bad side, if that makes sense. Because one's strong and one's unopposed, basically. No other one is damaged. Okay. So that can be either unilateral, or you can even be bilateral. So both can be damaged, and in that case, you're just going to have a overall sort of paralyzed tongue. But remember, there's no like fasciculations, because remember, fasciculations is a lower motor neuron problem. Okay, so lower motor neuron problem, that is the infranuclear like lesion, basically. So if you look at the brain again, upper motor neuron, nucleus, and then lower motor neuron, and then the muscles, right? So we're talking about either lesion here, like unilateral. Okay, so if it's unilateral, again, if it's the right side, you're going to have ipsilateral, because they don't cross over. So it's going to be this side, the right side gets affected, so the right side of the tongue will be affected as well. So that means the tongue is going to move towards that side, because there's unopposed action here. And if it's bilateral, which means both peripheral nerves get damaged, that means the overall tongue is going to become flaccid. It's going to become paralyzed. Of course, it's going to basically sink to the bottom of your mouth, basically to the floor of your mouth. And there's going to be fasciculations this time, because it's a lower motor neuron problem. Now let's talk about the big elephant in the room, and that's bulbar versus pseudobulbar palsy. This is a high yield topic that the professors in the department could easily ask you, maybe as a saving question, but it is generally a high yield and very important aspect. Okay, so bulbar, again, I told you what bulbar means. It means bulb actually means like in this case basically nucleus. Okay, so we look at bulbar, and this one means pseudobulbar. So this is fake or nucleus or whatever. So anyways, bulbar also refers to the fact that we're talking about the bulbar group of nerves, and that's 9, 10, and 12. Okay, so bulbar palsy literally just means a lower motor neuron lesion. Okay, so that means anything that includes the nucleus and the peripheral or the peripheral nerves. Okay, whereas the pseudobulbar palsy means fake, like not the bulbar nerve, so not the nucleus. So anything above the nucleus is damaged. So that means, the tracts, basically the corticonuclear tracts, those are damaged, not the nucleus. Okay, so this is basically an upper motor lesion. Okay, so those get damaged. So the symptoms of bulbar palsy are basically logical, because the bulbar group of nerves are 9, 10, 12. So it's kind of logical to see what would happen if any of these nerves were to get damaged. Okay, so for example, if the 10th or even the 9th, because they go hand in hand, remember, if those are damaged, you're going to get aphasia, because you can't swallow anymore, because your pharyngeal muscles are weak. Okay, so that means when someone tries to swallow, the food's going to go out from their nose, because there's no swallowing action. Okay, you're going to get aphonia, because again, these nerves innervate they're responsible for actually vocal cord innervation. So if you don't have that nerve that supplies that, then therefore you can't speak anymore. Okay, and also another thing is that you're going to have an absent pharyngeal reflex, of course, because these are the nerves which are responsible for the nucleus ambiguous. If you can look back at previous videos or read up about it, if that nucleus is damaged, you're not going to get any action of the pharyngeal arches to basically elevate, and you're going to see the uvula. The uvula is going to be, it's not going to be in the midline. Okay, that reflex is just gone. Okay, yeah, pretty much that's basically one of the main symptoms. And And then if we look at the pseudobulbar palsy, you're going to get, rather than aphasia, you're going to get dysphagia. And rather than aphonia, you're going to get dysphonia. So difficulties in speech. So the reason why you get dysphagia and dysphonia not complete is because remember, it's an upper motor neuron region that we're talking about here for the pseudobulbar palsy. So you're going to get hyperspasticity of the muscles. So the muscles are over sort of active. There's no fasciculations, whereas there are fasciculations here of the tongue, for example, in the bulbar palsy. So just think about like an upper versus lower motor lesion palsy. I know the names are very confusing, but if you just remember it that one's an upper and one's a lower, then it's actually quite easy to figure out what's actually going on. The main difference between the pseudobulbar and the bulbar palsy is that the pharyngeal reflex here is actually preserved. Okay, that's the main sort of big difference here, is that it's actually preserved, whereas in the bulbar palsy, because the peripheral nerves are what actually give off the efferent action. If those are damaged, you can't actually do the pharyngeal reflex, whereas in the pseudobulbar palsy, the upper motor, it's the upper motor neurons and not the lower. The lower motor neurons are still basically intact, so they can kind of basically still give an action, basically. So that's why they're preserved. What else is there? Also, there are some additional symptoms that you may see in upper motor, pseudobulbar palsy instead of bulbar palsy. You may get some emotional disturbances. Okay, and that's because it involves like the cortical sort of functions as well. Because if there's a lesion in the cortical functions, you're going to have basically unopposed, like uninhibited actions to occur. So that means your emotions are going to get more and more severe. So basically, the patient can actually present themselves with forceful laughter or crying, which is kind of weird. So you have emotional disturbances. You may even get primitive reflexes coming back, because if you remember from one of the very first lessons, that these oral automatisms, they come from uninhibited cortical sort of functions happening. So they were supposed to be inhibited, naturally in a normal human being, but when there's lesion in the cortical area, these reflexes come about. Okay, and unlike the pharyngeal reflex, being preserved, the mandibular reflex, for some reason, is actually very exaggerated. So when you do the jaw jerk reflex, it's massive. Okay. Remember, by the way, guys, that if you have a bilateral innervation, so both bilateral lesions, so if you have both lesions on both sides of the vagus nerve, that's basically GG, because first of all, the vagus nerves, I told you, is responsible for all the parasympathetic innervation, for cardiac, lung, and all that. But also the the vagus nerve is responsible for the closure of the larynx, the windpipe. So if that becomes closed, that's going to cause choking and suffocation, and you need instant intubation. So there's a neat little table here from the books. So you see here that there's atrophy of the tongue in bulbar palsy, which is a lower motor neuron. Okay, whereas the pseudobulbar palsy, you won't see that. Fasciculations, because it's a lower motor neuron. Again, you get complete aphasia in bulbar because of the lower motor neuron. You get aphonia in lower motor neuron. I told you about the emotional disturbances. You can't control emotions. You have an increased jaw reflex. Primitive reflex as well. And again, this is just to summarize that the bulbar palsy is all about the lower part. Anything above, anything after the nuclei, or including the nuclei. And this is anything to do with the the tract from the brain to the nucleus, i.e. the corticonuclear tract. So that was it for the bulbar group of nerves.